Department of Oral and Maxillofacial Surgery and also in the Department of Orthodontics at Texas A&M University College of Dentistry. Well, hello. I'm Dr. Larry Wolford. I'm clinical professor in the Department of Oral and Maxillofacial Surgery and also in the Department of Orthodontics at Texas A&M University College of Dentistry. And I'm in full-time private practice at Baylor University Medical Center in Dallas, Texas. The title of my presentation today is Recognizing and Treating Upper Airway Obstruction in Sleep Apnea. Obstructive sleep apnea syndrome is where a minimum of 30 recurring episodes of functional pharyngeal airway obstruction that last at least 10 seconds each during a 7-hour sleep period. Sleep apnea is generally classified and rated as an apnea-hypoxia index, AHI, or respiratory disturbance index, RDI. Mild obstructive sleep apnea is when there are 5 to 15 events that occur per hour during sleep. Moderate obstructive sleep apnea is when there are 15 to 30 events per hour during sleep. And severe obstructive sleep apnea is when there are 30 plus events per hour during sleep. Also, sleep apnea is considered an issue when the oxygen saturations decrease 3 to 4% or greater than the pre-sleep oxygen levels. These are some of the symptoms associated with sleep apnea syndrome: recurrent episodes of cessation of breathing while sleeping, frequent awakening and restless sleep, snoring and mouth breathing, nightmares, daytime sleepiness or somnolence, and poor work and school performance. These are some of the conditions that can occur with sleep apnea syndrome: high blood pressure, cardiac arrhythmias, right side heart failure, pulmonary hypertension, carbon dioxide retention, cyanosis, polycythemia, and sleep apnea can predispose patients to stroke, heart attack, and premature death. When upper airway obstruction occurs in a young patient, such as an infant, as that individual grows and develops, that airway obstruction can cause and have an adverse effect on facial growth and development, on the health and well-being of the individual, and can cause functional and aesthetic outcome issues. As you see in this lady here who had obstructive sleep apnea her entire life, her facial structures have grown downwards and backwards. Typical growth pattern for someone with sleep apnea in childhood. Now, when I evaluate upper airway obstruction, I look at it in 3 different anatomical areas: obstruction caused in the nasal airway cavity, airway obstruction created in the oral cavity environment, and the third area is the oral pharyngeal airway. Now, patients may have one or all 3 of these areas of obstruction in the presence of sleep apnea. So let's look at the nasal airway area first. So the first area that we can have obstruction is at the nostrils of the nose. where the nose may be malformed, perhaps had a previous rhinoplasty where too much cartilage was removed, and causes significant constricture of the nares. Another contributing factor to creating narrow nostrils and obstruction at the orifice into the airway is a wide columella. And that's caused by excessive soft tissue that develops between the alar feet of the alar cartilages. A little bit deeper in, we have what's called the luminal or the nasal valve. It's a constricture of tissue in here that's normally there, but it's usually not real significant. But if that luminal valve is constricted, it can cause a significant narrowness of the inner aspect of the nostril, restricting airway and airflow. A little further inside, we have the nasal turbinates. And if they're normal in size, patient should have normal nasal airway function. But they can become excessively large to where they become almost totally obstructive. This can be a cause of nasal airway obstruction and of sleep apnea. Nasal septal deviation can also be a contributing factor, where the septum gets deviated off to one side and can block the airway. And here you can also see in this patient, in this coronal view, you can see the enlarged turbinates, these large gray areas here that significantly obstruct the airway. In this view, the black area here is the functional airway, very constricted. This patient cannot breathe through their nose. This is an axial view looking downwards, and you can see the airway is very, very constricted here, the black area. Another area of obstruction, particularly in younger kids, is the adenoid tissue. Normally the posterior pharyngeal wall runs down like this, but we can have adenoid tissue in here that can block the airway significantly. The posterior aspect of the nose and oropharyngeal area. Then we get into the areas of the oral airway where we can have obstructions. Here in the view of the occlusion, if the maxilla transversely is narrow and the mandible is narrow, this can displace the tongue posteriorly, contributing to airway obstruction and sleep apnea. On the right-hand side, we can see a patient with a severely retruded mandible. Maxilla is also retruded. This can cause sleep apnea as well by displacing the tongue posteriorly into the oropharyngeal area. Macroglossia, a large tongue, can cause a malocclusion, as you see in the left-hand side, but also, because of the size of the tongue can become posteriorly displaced, causing an airway obstruction at the back of the airway area. Another area involves the soft palate and the uvula. In this case, we're looking at the soft palate, which is elongated. We see a uvula that's sort of folded on itself, but very broad and contributing to the obstruction. We then have the posterior fascial pillars. They're causing some narrowness in the transverse width of the oropharyngeal area that can contribute to airway obstruction and sleep apnea. Another area of obstruction are the tonsils. Sometimes on x-ray we can see where the tonsils are positioned, but they can become quite large, as you see in the clinical photograph here, and become quite obstructive. If they get inflamed or infected, they can become even larger, causing significant airway obstruction. One of the largest contributing factors to sleep apnea, however, is decrease in the oropharyngeal airway dimensions. Distance between the soft palate and the posterior pharyngeal wall, base of tongue and posterior pharyngeal wall. The normal dimension there is 11 millimeters, plus or minus 2. In patients with sleep apnea syndrome, they commonly will have a decreased dimension at the oropharyngeal area. Well, the kind of patient that most commonly has sleep apnea is what we term the high occlusal plane angle facial morphological patient. And these are some of the aesthetic characteristics that you might see. They're dolichocephalic. They may have lip incompetence. They may have an excessive exposure of their upper tooth to their upper lip relationship. They may have a gummy smile. They may have a high, poorly defined mandibular plane line. In profile, they may have a retruded mandible, retruded maxilla. The nose sometimes will look quite prominent when in fact that's just an illusion related to the upper and lower jaws being retruded. Oftentimes they will tend to tip their head upwards and forwards as this helps open up the airway at the back of the throat. They commonly have a short chin-neck line and the chin-neck angle is poorly defined. They have this high mandibular plane angle facial morphology. So patients with high occlusal plane angles can have a class 1, class 2, or class 3 occlusion in skeletal relationship. As the angulation of the occlusal plane approaches the slope of the articular eminence, then patients will lose incisal guidance. They will lose the cuspid rise protective occlusion function. They may develop posterior functional interferences as they go into excursion movements. They may tend to develop anterior open bites. They are the most likely type of patient to have posterior cross bites and a transverse narrow maxilla. Cephalometric analysis is quite helpful in identifying these patients. So these patients will commonly have a high occlusal plane angle, and that's defined by the occlusal plane line that bisects the occlusion and the angle that makes with Frankfurt horizontal. That normal angulation is 8 degrees. In this particular cephalometric analysis, you can see the patient is at 20 degrees. You can also see that the maxilla is retruded. There's an excessive amount of tooth to lip relationship. Mandible severely retruded. And then this combination could cause a decrease in the oropharyngeal airway. So these types of patients with a high occlusal plane angle facial morphology present with a dental facial deformity. But this patient facial type is also the most common patient to have hypertrophy turbinates. Most common type of individual to have nasal airway obstruction. Most common type of individual to have a decreased oropharyngeal airway. Most common type of individual to have sleep apnea syndrome. And importantly, the high occlusal plane angle patient with these morphological characteristics are also the most common patient to have TMJ pathology. What does this mean? This means if you're treating patients with sleep apnea, you need to look at these clinical and cephalometric characteristics. You need to understand that they may also have TMJ problems that may need to be addressed in order to have a predictable, stable, pain-free outcome. Well, these are some of the non-surgical management methods for sleep apnea patients. Weight loss, for those that are significantly overweight, can be helpful. Changing sleep posture, in other words, keeping people from sleeping on their back, making them sleep more on their sides or stomach. External nasal airway devices, such as the nasal airway strips to help expand out the lateral aspect of the nose. Oral airway devices. Mandibular anterior repositioning devices. And then we have the mechanical factors such as continuous positive airway pressure machines, or CPAP. Now, what do sleep apnea appliances generally do? They're generally manufactured to take a lower jaw that's retruded, or even in normal position, but where there is a decreased oropharyngeal airway, and it holds the mandible forward. If you can hold the mandible forward, that can open up the airway space at the back of the throat some. However, these devices also can cause significant alteration over time in the occlusal relationship. These devices can cause dental movements because of the nature of the forces placed on these devices. It can cause the lower teeth to be pushed forward, upper teeth to be pulled backwards, resulting in a malocclusion. Then we have the CPAP machine. It's the device of choice for the medical people, particularly the pulmonologist involved in treating sleep apnea, as it forces air down through the nose and or mouth into the lungs. And so with force, it allows air to be exchanged with the pulmonary system. But it is a cumbersome device, and some patients cannot tolerate it. So when devices fail, or patients prefer other alternatives, then surgery is a consideration. Well, the most tried and true treatment of sleep apnea that's been used for probably 100 years is a tracheostomy. What this does is it totally bypasses the entire upper airway obstruction. It's not the best technique. There are a lot of complications. Obviously, with the tracheostomy in place, it's very difficult for patients to talk. It is a constant irritation in the trachea and pulmonary system. So although it works, bypasses the upper airway obstruction, it does have its consequences and liabilities. One of the most common techniques used by our ENT otolaryngology colleagues is the UPP procedure, where they cut off the posterior aspect of the soft palate with either a Bovie, an electric cautery, laser, but they remove the tissue, but that subsequently can cause a fibrous band to develop in here, which can limit the mobility of the soft palate and may cause some other constrictures, and is generally not terribly effective unless the only obstruction is with the soft palate. But commonly these patients have other areas of involvement as well. So that's some of the surgical treatment considerations. And we're going to start from the top front, which means the nostrils. So if you have a wide columella but narrow nostrils, then one simple option is to do what I call the columella cinch suture, where I pass a suture, usually non-resorbable, usually like a 5/0 clear nylon, and I do little incisions into the tissues here, and then I'm going to pass a suture through the base of the alar feet, across the other side, and then I'm going to come back through again. So I'm doing like a figure of 8 passage, and then tie it. And what this does is it narrows the columella and allows the nostrils to widen. Relatively simple technique. This is in surgery. Patients had other treatments, obviously, but you can see the wide columella. And so I just did a little incision into the soft tissues. Oops. Here at the base of the nostril, just inside, pass that figure of 8 suture and cinch it down. You can see how we can narrow the columella and increase the size of the nostrils. Further back inside, where we have the luminal valves or nasal valves, whatever you want to call them, this is a consideration that I commonly will use, where I will do multiple Z-plasties to break up that constricture. And sometimes underneath here, though, in this area underneath here, and what causes the constricture sometimes is the scrolling in of the lower lateral cartilages. So when I do this incision with the multiple little Z-plasties, I may also excise a portion of the posterior aspect of the lower lateral nasal cartilage, and then place a nasal stent to help mold that and eliminate that banding inside the nose. And so we hopefully can get this kind of an outcome, where we can have a nice open nasal luminal valve. Another area that patients may complain of is if the lower lateral cartilages in this area here are very, very thin, or if patients have had previous rhinoplasties where a lot of that lower lateral cartilage was removed, we have significant weakness in the lateral walls of the nose, so that when the patient breathes in, this area falls in and collapses the airway at the luminal valve area and makes it hard for the patients to breathe through their nose. So support grafts can be placed into these areas to give support and strength to that area, so when the patient inhales, that area doesn't collapse. And these are called spreader grafts. So when I do these techniques, probably what I like to use the most is the lateral wall of the maxilla. I just go up here and in the posterior aspect, just excise some bone from both sides if I'm doing it bilaterally. You can also use the vomer back in here. You could use some of the cartilage, except the problem with the cartilage is it's so much thicker compared to the maxillary bone. So I prefer to use, most of the time, some of the maxillary bone. And then I just do an intercartilaginous incision, dissect back over the posterior aspect of the lower lateral and upper lateral nasal cartilages, create a pocket in here, and then I'm going to take my bone and I'm going to graft it into this area, placing it from intranasally. So here I've harvested some bone. You can see here where I'm going to put them. I've already done my dissection. And then through the intranasal incisions, then I'm inserted that bone up underneath the nose here on both sides. Usually I don't need to secure it, but in this case I did secure it. I ran some sutures from inside the nose through the graft and outside, put a little cotton pallet here and tied it over. Use that as a little bolster just to help support it and center it while the patient undergoes that initial healing process. So here's the patient before, immediate post-surgery, then longer-term follow-up. And what we've done is we've made these areas here much more rigid. So when the patient breathes in, that lateral nasal wall no longer will collapse in. Now we'll go back in a little bit further. The next structures we come to are the nasal septum and the turbinates. So this is a study that was done on 1,234 cases in which I did maxillary osteotomies. And what we looked at were how many of these cases required turbinectomies and how many of these cases required nasal septoplasties. So the patients were evaluated with cone beam CT evaluations. We're looking at the size of the turbinates. And we correlate this with the clinical issues that the patient has breathing, as well as the radiographic evaluation. And we also looked at the septum. In this case, you can see the septum's deviated way out and actually touches against the lateral nasal wall here. That's how deviated the septum was on that particular patient. So we're looking at those factors, and then we're going to treat those. So what we saw was in the patients that required maxillary Lefort 1 osteotomies, and many of the cases that I treat are high occlusal plane angles because of them having TMJ problems, because of them having sleep apnea. What we found was that 49% of those patients required partial inferior turbinectomies to reestablish a normal nasal airway. 22.5% also required a simultaneous septoplasty to help reconstruct the functional airway. So when I'm doing the partial turbinectomies, I'm doing it with a maxilla rotated downwards. After I've done my Lefort 1 osteotomy, the maxilla is rotated downwards so I can go in into the nasal cavity from beneath to do the resection. I'm going to take off about a half to a third to a half usually of the inferior turbinate, leaving some behind to open up the airway. So this shows the approach. The maxilla has been mobilized, rotated down this way, and an incision through the nasal mucoperiosteum, and then you can see the turbinate sitting right up underneath there. And so we resect whatever is necessary to open up the functional airway. So here we see a patient with enlarged turbinates, difficulties breathing through the nose. Following resection, we still have maintained nice size turbinates that are still quite functional, but allow this patient to have a normal functional nasal airway. Now, the other thing we did in this study, we looked at the skeletal profile to try to identify which patients required the turbinectomies. And that's where we saw that patients who had maxillary and mandibular AP hypoplasia, those patients with high occlusal plane angle, facial morphologies, were the most common type of patient to have hypertrophy turbinates and deviated nasal septums. Very, very strong correlation with those two factors. So the results of this study, 1,234 patients, all patients reported improvement in their nasal airflow and nasal breathing capacities following surgery. None worsened. So now we're going back into the oropharyngeal area, and the first obstruction we may come across may be hypertrophied nasopharyngeal adenoid tissue. Now, normally the posterior pharyngeal wall is coming down like this. Here we can see a large adenoid mass on this patient. Most of the time, the adenoids resorb away by the age of 12 to 14. But in some patients, they can stick around for a long time. We even occasionally see them remaining in adults. And this can cause some significant obstruction. In this patient, the posterior nasal turbinate is right there. This is the turbinate. And you can see there's virtually no airway for this patient in this area. So if we're doing orthognathic surgery and we have a patient with hypertrophied adenoid tissue, then I remove it at the same time that I'm doing the maxillary osteotomy. Here I've rotated the maxilla down. You can go straight back off the posterior border of the hard palate, a little incision through the mucosa, and you have direct access to the nasopharyngeal adenoid tissue. So you're looking back in here. Here's a maxilla rotated downwards. And looking way back in the throat, and here you see the adenoid tissue right there. There's some on the other side here as well. And I just use a adenoid curette and just curette out that tissue. There's the tissue removed, and now you can see that the adenoid tissue has been removed for this patient. Relatively simple technique, can be done at the same time as the orthognathic surgery if the adenoid tissue is a contributing factor to sleep apnea. Now, the next area that we'll look at is when the soft palate and the uvula are hyperplastic. So this is the way that our colleagues commonly treat this, probably some oral maxillofacial surgeons as well, is that you go in when the soft palate and uvula hyperplasia is contributing to sleep apnea. You go in and you cut off the posterior aspect of the soft palate with a scalpel, bovie or electric artery, or laser. You just remove the back part. Now, the one problem with this, however, is this the bovie and laser particularly are very traumatic to the soft tissues. They burn. It's a burn used to remove the tissues. And not only is this extremely painful, but also can cause significant scarring of the posterior border of the soft palate. And then we get what we call, what I call the curtain effect, where we get the scar tissue. It narrows the posterior fascial pillar area here and really restricts the movement and function of the soft palate. It can, therefore, create other issues such as hypernasal speech quality. So we get this sort of what I call curtain effect, just dense tissue, scar tissue down that area that restricts the function of the soft palate. It tethers the soft palate. So here you see a typical patient with a hyperplastic soft palate, hyperplastic uvula. Here are the fascial pillars, quite constricted in transverse width. So the technique that I developed involves reducing the size of the uvula and shortening the soft palate with a very specific technique, as you see illustrated here. So basically what I do is I do a wedge resection of the hyperplastic uvula, and then I'm going to sew this together here. And then I'm going to do some lateral incisions out into the fascial pillars, the medial fascial pillars. And then basically what I'm going to do is I'm going to take this end right here. I'm going to dissect up into the soft palate here, create a little tunnel up through here. I'm going to pass a suture from up here down through, catch this edge right here, and pull it back up through. And so basically what we're trying to do is pull that soft palate forward and out laterally to open up the oropharyngeal airway and also make the transverse width of the oropharyngeal airway to soft palate level much wider. So here's what it might look like afterwards. Done the uvulectomy, did my incisions out here, undermined up into the soft palate, and then took this corner here, brought it up and out this way, this corner here, and brought it up and out this way, and tucked it inside the soft palate. I call it the lateral inversion flap technique. But it allows us to have this nice broad width back here with this technique, but preserve the posterior border of the soft palate so that it doesn't become fibrotic. Next area where we can have issues is with an enlarged tongue. And so there are times when a reduction glossectomy is indicated to decrease the size of the tongue, to improve the functional and occlusal treatment outcomes if the patient requires orthognathic surgery, and opens up the oropharyngeal airway. So I do the keyhole technique where I go in here and I'm going to cut almost like a keyhole design and remove that tissue and then just sew up like this, and this will reduce the width of the tongue as well as shorten it anteriorly and posteriorly to allow it to fit better into the mouth. So here you see a lady at the top. She's got a huge tongue. She's got an anterior open bite. You see how large her tongue is. She just relaxes it and it covers her teeth. Cephalmetrically, she has a severely decreased oropharyngeal airway, 5 millimeters here. Remember the normal AP dimension there is 11. So all I did on her is I did some orthognathic surgery. I didn't advance her jaws at all. We just sort of closed up the open bite. So I actually decreased the oral cavity space somewhat with the orthognathic procedures. But just by reducing the tongue, the width and dimension increased to 10 millimeters. So what we did, in this case, by reducing the tongue, we doubled the size of the oropharyngeal airway. Now what happens when you double the size of the oropharyngeal airway? Well, you increase the airflow with the same amount of resistance. The amount of airflow increases 4 times what the airflow was in the original position. So if you double that airway, you're going to increase the airflow 4 times what it was beforehand. Huge improvement for patients. Another contributory area of obstruction is tonsils, a particular problem in younger kids. Usually not much of a problem in adults, but occasionally can be. But when you have these huge tonsils in here, they take up a huge volume of area back in the oropharyngeal area, and it can cause a significant contribution to sleep apnea problems. Enlarged tonsils in a very young population can actually push the tongue forward and cause a anterior open bite to develop. So when you're evaluating patients, be sure to look at their tonsils, particularly if they're a very young patient with an anterior open bite. It could be because of those tonsils. Removing those tonsils then earlier would be possibly indicated. And here's the patient I treated. You can see these huge tonsils. And we took them out. Got good hemostasis. And you can see now just how much clearer the airway is back in here. So the next problem we have to deal with is just a decrease in the oropharyngeal airway. And this commonly is caused by the high occlusal plane angle facial morphology, the retreated mandible, retreated maxilla, causing a significant decrease in the functional airway back here. Remember, the normal dimension across here should be 11 millimeters. This patient is significantly constricted. So when we do these counterclockwise rotations that you see here, that airway can open up significantly. Advancing the maxilla mandible forward in a counterclockwise direction in these high occlusal plane angle patients with sleep apnea is the most predictable method to correct obstructive sleep apnea. Now, I introduced this concept of counterclockwise rotation actually back in 1981, and this was my first patient. This young girl had cerebrocostomandibular syndrome. A few of these kids survived beyond the first decade because of their severe sleep apnea and difficulties breathing because of calcifications of their ribs. But this is how she presented. You can see the severe retreated mandible. And this is her presenting cephalometric analysis. She has this real high occlusal plane angle. Incredibly narrow oropharyngeal airway. Extreme difficulties breathing. Well, this is back in 1979. Back then I did what we normally did. We just advanced the mandible forward. Back one slide here. No, it won't let me reverse here. Let's see. Well, I'm sorry that I lost those couple slides, because she was the first person that had a counterclockwise rotation of the maxillomandibular complex. I advanced her forward an incredible amount by lengthening the vertical height of the mandible, as well as downgrafting the posterior aspect of the maxilla. Dropped the maxilla down like 10 to 12 millimeters. And I did it with a technique because back then we didn't have rigid fixation, but I used what are called threaded Steinman pins. You can see in the upper illustration coming out of the cheeks, there's some threaded Steinman pins that I screwed into the zygoma and attached onto the first molars and stabilized it there, as you can see in the lower right-hand screen. And this stabilized the maxillary and mandibular complex. I had to bone graft the maxillomandible, but we're able to achieve an incredible outcome for this young lady. So I think I've got problems. My program is frozen. I don't know if the technicians can come on and fix this for me. can't get it to go forwards or backwards. Is anyone there to help me? Okay, I'll see if I can do it myself. Sorry, there'll be a short interruption here. So let's see if I can get out of this and come back in again. I'm so sorry. Let's see if it'll work now. Yeah, if y'all can help me, I would really appreciate it. It jammed up again. It's never happened before. I don't know what's going on. Okay. See if I can move this out of the way here. I can go in and see if I can restart my talk. So sorry for those listening in. See if we can get down to where we were. Then where am I? Okay, here we go. All right, we'll start here again. This is where we were before. And there, hopefully we're back in business. We'll see if this will work for us. So this is our young girl. Again, this is her cephalogram originally in 1979. I advanced the mandible forward, did a big chin implant, but her airway barely opened up because what I did is I came down that steep occlusal plane angle. That doesn't open up the airway. So I took her back to surgery in 1981 when I figured out what was going on. And so I downgrafted the posterior maxilla, lengthened the ramus, 18 millimeters, this counterclockwise direction. So her chin point came forward a total of 35 millimeters. Now this is before rigid fixation. And we just had wire techniques back then. So what we did is we used these threaded Steinman pins here. I put into the zygoma because we didn't have any other form of rigid fixation. Attached that, in her case, to her lower molars, and left that in for a few months. And this is her actual X-ray from February of 1981. You see, it's just all wire fixation, suspension wires, and so forth. But I use these thread Steinman pins here fastened them on to the lower first molars, and provided stabilization that enabled us to get this kind of result at 4.5 years post-surgery. Again, back in 1981, what's that, 40 years ago, this is what we were able to achieve at that time without rigid fixation. And this worked so well that we then began using this routinely to correct patients with significant jaw deformities with that high occlusal plane angle facial morphology and those with sleep apnea. You can see the significant improvement in her airway, really good stability at 4.5 years post-surgery, and a good stable occlusion. So here's a lady, a typical patient. She's got sleep apnea, but she also has TMJ problems. She has retreated mandible. She has that high occlusal plane angle facial morphology. So when you see this kind of facial shape, retreated mandible, retreated maxilla, the things you've got to think about: nasal airway obstruction, decreased oropharyngeal airway in sleep apnea, and TMJ problems. Again, this high occlusal plane angle facial morphology is the most common type to have TMJ issues. So this is this lady's cephalogram. She's retreated in a maxilla mandible. She has decreased oropharyngeal airway of only 2 millimeters, and she has TMJ problems with articular discs that are anteriorly displaced. This is her occlusion. She had had previous orthodontics, so her bite was fairly good. So I treated her. We put her disc back in place, and then at the same time did the orthognathic surgery with a counterclockwise rotation, a little genioplasty. So her chin point came forward here 21 millimeters with this counterclockwise rotation. Counterclockwise rotation is the most effective way to treat sleep apnea, plus develop the best aesthetic outcomes for most people with sleep apnea. Maxilla was downgrafted in the back here. Allowed us to get this kind of an outcome for her. Improved her facial asymmetry as well. Improved her profile. Established a good occlusal relationship. See on the right-hand side is a post-surgery occlusion. And importantly, her airway improved significantly. So with alteration of the occlusal plane, this can affect the oropharyngeal airway, mainly related to the changes in the position of the mandible. So with this counterclockwise rotation, this is a study we published a few years ago. The average advancement at point B was 7.5 millimeters. And what we saw was the tongue base move forward about 76% of the amount of mandibular advancement. So let's say the mandible advanced forward 10 millimeters, the base of the tongue came forward 7.5 millimeters. The soft palate follows the tongue forward, and it comes forward about 50% of the amount of the mandibular advancement at point B. Now, conversely, if you're treating a prognathic patient and you're setting that mandible backwards, you want to make sure that you have more than the normal airway at the oropharyngeal area, because when you move the mandible backwards, the tongue base moves backwards 65% of the amount of mandibular setback. The soft palate moves back almost 50% the amount of mandibular setback. So when you do prognathisms, you need to look at that airway to make sure that that patient's not going to develop a sleep apnea problem post-surgery. So that's what happens. You move, set it back 10 millimeters. You're going to decrease back here 6.5 3.5 millimeters. You're going to decrease up here 4.7 millimeters. So you need to make sure that that airway is greater than normal when you treat a prognathic patient by setting the mandible backwards. So posterior airway space changes after double jaw orthognathic surgery with counterclockwise rotation. This is another study we did, 72 patients in the study, followed up for about 3 years. Surgical technique was maxillary and mandibular advancement with counterclockwise rotation. And what we did is we looked at the amount of advancement at point B at 3 different amounts of advancement. For the first group, the amount of advancement was about 7.4 millimeters, and it was 0 to 10 with an average of 7.4. The second group, we advanced 10 to 15 millimeters at point B with an average of about 12.5 millimeters. In group 3, we advanced greater than 15 millimeters for an average advancement at point B of 20 millimeters per patient. Now let's look at what happens with the oropharyngeal airway. So what happened here was that in the first 10 millimeters, we got the greatest amount of change, 66% of the amount of mandibular advancement. So if we advanced 10 millimeters, the oropharyngeal airway opened up 6.6 millimeters. That's pretty good. Now, in the second group, the larger advancements, we get less improvement in the airway with the greater the amount of advancement. So if we advance 10 to 15 millimeters, the airway increased about 56% of the amount of advancement. But when we got larger than the 50 millimeters advancement, the airway improvement overall was a smaller percentage, only 41% of the amount of advancement. So we get the greatest change in the first 10 millimeters of mandibular advancement. Then as our advancement increases, we get a smaller amount of impact in improvement in the oropharyngeal airway. So again, we get the greatest change for that first 7.5 to 10 millimeters. So here's a young patient, 16 years old. She's got sleep apnea. She's got some TMJ problems. See her bite shifting into a open bite. She probably has adolescent internal condylar resorption that we talked about on Monday. So her mandible is slowly shifting backwards, is slowly decreasing her airway dimension. And it's in part due to the fact that she has anteriorly displaced discs related to adolescent internal condylar resorption. So in these people, if the disc and condyles are still salvageable, I put the disc back in place with the MyTech anchor technique. And then concomitantly did the orthognathic surgery. In this case, we advanced her chin forward at point B, 12 millimeters. Maxilla came forward 4 millimeters, downgrafted it posteriorly. But we did this counterclockwise rotation. Again, gives us the best airway change and in most cases the best aesthetic change. And here she is afterwards. Improvement in her profile. And a good stable occlusion. Now, if I would not have addressed the joints, if I would not have put the disc back in place, she would continue to have condylar resorption. She would have relapsed from where we placed her. So fixing the joints, getting a stable joint outcome is paramount to having a good, stable outcome in these patients. So a good airway, well within normal range. Now, not all of our patients are the young, attractive patients, and this is a more common type of patient, a more elderly patient. She was in her 50s or early 60s when I saw her. I can see how severely retruded her maxilla and mandible is. She has virtually no chin neckline at all. She has severe sleep apnea. She's on a CPAP machine. But her occlusion is not bad. I mean, it's acceptable, functional for 56. She's 62 years old for a 62-year-old female. But she has this high occlusal plane angle, facial morphology, severely decreased oropharyngeal airway. Top of that, now she has a hyperplastic soft palate. Her soft palate and uvula are much longer than normal. So while we are doing the orthognathic surgery and the counterclockwise rotation of the maxillomandibular complex, I'm also going to do a uvulopalatopharyngoplasty, that special technique that we developed. We can do that at the same operation. So we're going to bring her forward. We're going to do a little genioplasty here. So Pagodion is going to come forward a total of 24 millimeters. See what we're doing with the maxilla. We're going to advance it forward, downgraft it posteriorly. We're doing a multiple piece of maxilla. We're going to upright the anterior segment, bone graft in here, bone graft back in here, sort of all around. But it enables us to get this kind of a result for her. We're able to totally eliminate her sleep apnea, get her good, stable, functional, and occlusal result, significant improvement in her aesthetics, and a good, stable outcome. And here you can see results of the UPPP procedure. Again, done at the same time as the orthognathic surgery. And her airway afterwards. See how much we shortened her soft palate with UPPP with my special technique? You can see how much we opened up the airway back here. Significant improvement. Another patient, and this is an airplane pilot. He flies commercial airplanes. He come in complaining that he falls asleep while flying the airplane. So he's putting all the passengers at major risk. But his main problem is his maxilla and mandible are significantly retruded. Now, when he was younger, he had orthodontics, and he had 4 first bicuspids extracted and all the teeth retracted backwards, posteriorly, to get the teeth together. But when the orthodontist did this, they also significantly compromised his airway. They actually induced sleep apnea. I see this quite frequently. Patients coming in their 40s, 50s, 60s with significant sleep apnea. You look at their occlusions and they had bicuspids extracted. And oftentimes what happens is these patients have a normal maxilla, but they have a deficient mandible. So instead of fixing the deficient mandible, the orthodontists extract teeth, retract the maxilla, the normal maxilla, back to meet the deficient mandible. Now we have a retruded maxilla and mandible. So here's his lateral cephalometric radiograph, high occlusal plane angle, retruded maxilla, retruded mandible, significantly decreased oropharyngeal airway. And what we plan to do, just a counterclockwise rotation. Mandible's going to come forward 13 millimeters. We're just going to rotate around and up like this. Maxilla is going to advance 9, downgrafted posteriorly. Enables us to get this. On the left, pre-surgery. In the middle, 1 year post-surgery. And on the right-hand side, 4 years, 7 months post-surgery. Showing maintenance of good facial balance. Good aesthetics. And a good airway. Again, with increased in the airway that we were able to achieve for him, the amount of airflow he can get through is probably 4 to 6 times what he could get through before. Now here you can see the change, and it's a little hard to see. The dotted line is pre-surgery. And so here is his posterior pharyngeal wall before, back of his soft palate. You can see how narrow he is here. And then the straight line here, the solid black line, is where his airway opened up to. Significantly improvement in the dimension of the airway. What also happens with these patients is their head and neck posture will change as well. They'll start to function with their head in a more normal position, postured over their neck and shoulders. So we do see that frequently in sleep apnea patients, where pre-surgery they hold their head and neck forward because they can breathe easier. Post-surgery, they can assume a more normal posture. He has a very stable occlusal outcome at 4.5 years post-surgery on the right-hand side. And his soft palate. Now this is, we use our special technique. You can see how nice and wide that is back there. A little remnant of his uvula still there, but nice tissues, nice flexibility of the soft palate compared to what it was before. Now the TMJs, again, we touched on this on Monday. We're going to just hit briefly here since it plays such a major role in sleep apnea. But the TMJs are the foundation for jaw position, occlusion, facial balance, TMJ and jaw function, growth and development. Importantly, airway function, comfort, dental, orthodontic, and surgical outcome stability. So TMJ pathology, and I'm going to try that again, TMJ pathology can adversely affect any of these factors, or all of them as mentioned above. So these are the most common TMJ conditions associated with sleep apnea: articular disc dislocation, adolescent internal condylar resorption, reactive arthritis, ankylosis, particularly when it occurs in young growing patients, trauma, subcondylar fractures that are untreated, connective tissue autoimmune diseases such as rheumatoid arthritis, lupus, scleroderma, juvenile idiopathic arthritis. All those conditions cause condylar resorption that lead to the mandible becoming retruded that can cause sleep apnea. Deformed or absent joints such as hemifacial microsomia, Treacher-Collins, those kind of deformities. And other non-salvageable joint conditions such as the multiply operated joints, failed autogenous or alloplastic TMJ reconstructions that were done previously. These all can lead to the mandible becoming more retruded and creating sleep apnea issues. So if we have a disc displaced, as you see here, the way I treat it is I take out some of this intermediate zone, the bilaminar tissues, and I remove that out. I'm going to take this disc and I'm going to bring it back up and put it on top of the condyle, as you see here, and stabilize it with the MyTech technique. The MyTech anchor is inserted into the posterior head of the condyle, and then sutures attached to it are taken up and attached onto the posterior band of the disc to hold it in place. We talked about this in detail on Monday. So this is what it may look like. You're looking right here, the condyle and the fossa. Here's the anchor right there, holding the disc back in place. So the disc is probably sitting in about like this, and the ligaments from the anchor are going up through and holding that disc back in place. Here's a closer up of it. You can see the anchor right here. Here's the top of the condyle. See the hole here through which the artificial ligaments pass. So they go through there and they come out. And the disc is probably sitting up in this position here, and they come out and go through the disc and are tied right there. So this is a gentleman Severe sleep apnea. Severe sleep apnea. He was the CEO of a large company in California, but he couldn't stay awake in the board meetings, and so they asked him to resign. So he came for treatment. Let's see how severely retruded his mandible is. Severe sleep apnea. Occlusion's not too bad. He had orthodontics when he was younger. But he's got this high occlusal plane angle facial morphology. There's significantly retruded mandible and maxilla, and a significant decrease in the oropharyngeal airway. So he was treated with some orthodontics to set his teeth up so we could get a better occlusal outcome for him. Anteriorly displaced disc, high occlusal plane angle of 21 degrees. Remember, it's supposed to be 8 degrees. Significantly decreased airway back here. Remember, it should be about 11 millimeters. But disc out of place. So treated by putting his disc back in place in both joints, counterclockwise rotation of the maxillomandibular complex. Where the chin came forward 19 millimeters, maxilla advanced forward 8. Downgrafted the maxilla posteriorly half an inch, 12 millimeters. But used rigid fixation to stabilize the jaw position. And this is what we were able to end up with afterwards. You can see the bone plates here, synthetic bone here used to graft the maxilla, the plates and screws to stabilize the mandible with the sagittal split osteotomies. But look at his airway. His airway is huge back there. Huge airway. Totally eliminated his sleep apnea. It's unfortunate he didn't come before they fired him from the board of directors of his company, because he could have functioned so much better. This totally changed his life. And his energy level, he just became so involved in exercise and skiing and so forth. His life was changed because of his airway improvement. Look at that airway, 19 millimeter airway. Just incredible, just with that counterclockwise rotation of the maxillary and mandibular complex. Importantly, however, we had to fix the joints. If we wouldn't fix the joints, he would have a high risk of developing pain and headaches afterwards, and he would have a significant risk of having condylar resorption with that amount of advancement, that amount of loading to the joint. So fixing the joints is critical in these patients with pre-existing TMJ issues. So here's what we're able to end up with for him. I think significant improvement in his profile and a good stable occlusion. So adolescent internal condylar resorption, we talked about this before, occurs predominantly in teenage females as they go through puberty. They have resorption of the condyles here. So the mandible slowly but progressively becomes more retruded. They all have displaced discs that early on oftentimes become non-reducing. So many of them have no symptoms. 25% have no symptoms with their joints, no clicking or popping, and no pain because it's a non-inflammatory process. There's no other joints involved and no genetic correlation. The amount of resorption we calculated to be 1.5 millimeters per year here at the condylar head that it resorbs. We think it's hormonally mediated, and the synovial tissues undergo changes that start to produce chemical substrates that cause this resorption in the condylar head. And that destruction and consequently the retrusion of the mandible. So this young lady had adolescent internal condylar resorption. See the retruded mandible, retruded maxilla. Short chin neckline, not any really good definition there. Occlusion or bite starting to open a little bit in the front, shifting a little bit into class 2. More so on the left side. So you're looking at here, the fossa, condyle on the left side, and here's the disc internally displaced, way out here. Right side, condyle. Here's the disc, way up front here. Classic for adolescent internal condylar resorption. So she's got a moderately high occlusal plane angle. She's got a decreased airway back here. Displaced disc. She's got some, hypertrophy turbinates. She's got some vertical maxillary excess here. So we're going to treat her by, first of all, putting her disc back in place with the mytech anchors, sagittal split to advance the mandible forward some. We're moving the maxilla upwards about probably 5 millimeters. And so the mandible is going to auto-rotate up and forwards even more. And we did a little genioplasty here. So chin point here came forward, a total of 13 millimeters. Maxilla advanced forward some, moved up some. Rigidly stabilized. Enabled us to get this kind of a result. Improvement in her profile. Good stable occlusal result. Again, this would not be stable if I would not have fixed the joints. Fixing the joints is critical for stability in these cases. But look at her airway. Significant improvement in her airway. Total elimination of her sleep apnea. But key, fixing the joints. So this is a young man with juvenile idiopathic arthritis, severe condylar resorption, severe retrusion of the mandible, significant sleep apnea issues. He was only about 16, I believe, when I first saw him. His occlusion, he's already had bicuspid extractions, everything retruded backwards, trying to get his teeth together. Obviously, they were unable to accomplish that orthodontically, but left him with a significant deformity in conjunction with really severe TMJ pathology. And here you can see with juvenile idiopathic arthritis, JIA, his articular eminence has resorbed away. So his condyles and condylar necks are totally resorbed away, and he's functioning with what's left of his condylar neck element on the residual of what's left of the articular eminence. You commonly see this when this condition begins at a young age. So I guess I saw him when he was about 19 years old. Very high occlusal plane angle, very constricted oropharyngeal airway. So in JIA patients, we have to use total joint prostheses to get the best outcome. Mandible lengthened 21 millimeters. With the genioplasty, his chin point came forward a total of 38 millimeters. Maxilla advanced 10. Moved it up in front a little bit, down in the back 8 millimeters. That allows us to get this kind of an outcome. Significant improvement in his profile and his airway. Good stable occlusion. In these kind of cases, you cannot achieve these kind of results without using a custom fitted or patient fitted total joint prosthesis. No way to do it. So here he is afterwards. You can see he's got a perfectly normal airway. afterwards. Very nice facial profile. Very good occlusion. Occlusal plane placed into a relatively normal position. Now again, here the dotted line, this is his airway before. Very constricted in here and in here. Then afterwards, his airway goes from here out to here, well within a normal airway range. Again, you can see how far the chin point came forward. It was back here and came all the way out to here. So advanced a total of 38 millimeters at Pagonion. Patient with a similar kind of condition, juvenile idiopathic arthritis. See the severe retrusion of the mandible. Occlusion changing. She's already had 4 bicuspid extractions in the attempt to get the occlusion together. And there you can see her steep occlusal plane angle. See her constricted airway back here. And just a tracing. Really high occlusal plane angle of 25 degrees, extremely constricted oropharyngeal airway. Again, the articular eminence is totally eroded away, as is the condyle, but the condyle functions what's left of it forward in the fossa. Doesn't function back in the fossa. In these young kids, when it occurs early, condyles function forward underneath the resorbed articular eminence. Again, best treatment is the total joint prosthesis to reconstruct the joint and advance the mandible. So we're lengthening here, pushing things forward in a counterclockwise direction. A little genioplasty here. Maxilla being advanced forward, downgrafted in the back. And this is the result. Pre-surgery, chin's back here. Post-surgery, forward to there. This is her stereolithic model prepared for surgery, and then the prostheses custom made to fit this patient's specific anatomical requirements as predetermined by my treatment planning. So that's what we're going to use to advance her mandible. So when we advance the mandible in this kind of condition, we also have to do a coronoidectomy, or you can't get the mandible down and forwards. You have to also, obviously, release the masseter muscles and the medial pterygoid muscles as well. And this is what the prosthesis in place, what it looks like. You see here 4 bone plates in the maxilla, used to stabilize the maxilla. And then the prostheses. And so this is what we were able to end up with. Everything brought forward, counterclockwise direction. What we're able to end up with on the right-hand side. Significant improvement in her profile. So it's pretty much normal. You'd never know that she had that deformity on the left side with the way she looks now. And a good stable occlusion. Another patient with juvenile idiopathic arthritis. She's got some facial asymmetries. Severely retruded mandible, maxilla. See that strong head posture forward neck position that goes along with so many patients who have significant sleep apnea. They have to hold their head forward just to breathe. Her occlusion. She's already had some bicuspids extracted in the bottom and up above. Some residual spacing yet. This is where she first presented. anterior open bite, and her cephalmetric analyses. High occlusal plane angle 31 degrees, normal supposed to be 8. Look at the severe constriction of her oropharyngeal airways, severe retrusion of the mandible, retrusion of the maxilla as well, little anterior vertical maxillary excess. So we're going to treat her with the total joint prostheses. It's counterclockwise rotation, downgraft the maxilla, advance it forward, advance the mandible, sizeable edge forward, about 13 millimeters. But the chin point with a little chin augmentation is going to come forward a total of 32 millimeters. So the red is where she was before. It's her chin back there, and here's where we came to. Again, this is her model, her 3D stereolithic model set up to where we want the mandible to be in its final position. Prosthesis made to fit. Radiographic examination afterwards, you can see the total joint prosthesis present on both sides of the mandible, and then the 4 plates in the maxilla stabilizing the maxilla. See the significant improvement in the airway back here. Improved profile. 4 years follow-up. See the significant improvement in the airway, 12 and 13 millimeters. Occlusal plane brought down to 9 degrees. Remember, normal is 8 degrees. Chin came forward 32 millimeters. Remained very, very stable. With these joint prostheses, the outcome stability when done in conjunction with orthognathic surgery is excellent. There's virtually no relapse if the correct prosthesis is used and if the surgery is performed properly. So here she is afterwards on the right-hand side. See the improvement in her profile, even improvement in her head posture and neck position. Good stable occlusion. Now, today there are a number of studies that can show the changes that can occur in 3 dimensions in the oropharyngeal airway space. So what you're looking at here is sort of a normal dimension of the oropharyngeal airway. The airway space there is just denoted with the red color. In B, this is a pre-surgery OSA patient. You can see the significant stricture, right here, that's contributing highly to the sleep apnea. Following maxillomandibular advancement, this dimension increases significantly. Advancement of the maxillomandible, particularly in the counterclockwise direction, is probably the most predictable way to correct obstructive sleep apnea when the obstruction is in the oropharyngeal area. So quality outcomes in orthognathic surgery for the correction of obstructive sleep apnea. We need to have an accurate diagnosis and treatment planning. Evaluate the TMJs, very, very important. Counterclockwise rotation of the maxillomandibular complex is very important to get the best functional and aesthetic outcome. Precise surgery needs to be done, including fixing the TMJ joints if that's indicated. Then appropriate post-surgical management of the patient is necessary to get the ultimate outcome for these people. So orthodontists and oral surgeons should be equipped to diagnose and treat sleep apnea. Why? Well, we have the radiographic tools. We have the lateral AP cephalometric radiographs. We have many of us cone beam CT scanners now in our offices. We know the oral cavity anatomy and relationships better than any other specialty. We have a basic understanding of sleep apnea and the causes. Some of us need to have a better understanding, but many of us have a very good understanding of the nasal and oral pharyngeal anatomy and how our surgery affects those particular areas. And we also understand the relationship between jaw morphology and sleep apnea. Again, this retruded mandible position, retreated maxilla, but particularly that mandible, is always a strong indication of obstructive sleep apnea. Also a strong indication for having hypertrophy turbinates inside the nose. A very strong indicator of TMJ problems. We understand the treatment options. We have the abilities to diagnose by observation and radiographs, which many other specialties do not have. And then we have the surgical armamentarium to treat sleep apnea, particularly those involved with upper airway obstructive issues. So that's the end of my presentation. I appreciate so much the opportunity to talk with you all. If you have any questions, please let us know, and I will be happy to answer those. If anyone has any questions, please send them in, and I will be happy to address those. Any questions? Okay, questions. How much is the maximum change in the inclination of the occlusal plane that we make? Well, basically, the changes I make with the occlusal plane is I assess the amount of occlusal plane inclination, obviously, in developing the treatment plan. If the patient has a high occlusal plane angle, then most likely I'm going to try to reduce that plane angle. If a patient has a low occlusal plane angle inclination, then I may plan to increase that occlusal plane angulation. The amount of change is based on my cephalometric analysis and my use of Frankfurt horizontal plane relative to the occlusal plane. And most of the time I'm trying to, I want to alter that occlusal plane angle for males to be about 8 degrees relative to the Frankfurt horizontal plane. In females, maybe a little bit steeper, maybe about a 10-degree angulation. So I'm using my cephalometric analysis to determine how much change to make in that occlusal plane. So I'm using degrees in that occlusal plane angle assessment. And I do use aesthetic measurements as well in determining where my occlusal plane is going to be with my cephalometric analysis. I'm looking at specific cephalometric analyses that I call maxillary depth and mandibular depth relative to the Frankfurt horizontal. It's difficult to describe, but sometimes I alter the position of Frankfurt horizontal plane so that my numerical values for maxillary depth and mandibular depth correlate to my clinical impression of that patient. And so we take aesthetics into strong consideration in our planning, in our positioning of the occlusal plane. Number 2, at what age for males and females is recommended to make a surgical assisted rapid palatal expansion. Well, I personally don't do that technique because I correct the transverse width at surgery, but you can do transverse palatal expansions with or without surgical assistance in younger patients where the suture line in the palate has not ossified. So up till probably 14, 15 years of age, you may be able to expand easily in a young patient. Once they get into the late teens or older, oftentimes the mid-palatal suture is ossified and will not expand without surgical assistance. So you can do surgical assistance then at any age. You can do what's called a SARPI. There's some other newer techniques with the morph or something like that. That are now available if you want to surgically try to expand the maxilla prior to doing your orthognathic surgery. So again, younger patients you can usually expand without surgery, but later teens and older patients doing like a Wolford 1 cut, separating the plates. Doing a midline split down the midline of the palate will enable you then to do a surgical expansion much, much easier. Thank you for the presentation. How often do I do total joint replacements with orthognathic surgery, and when do I do it in 2 operations? I do a lot of total joint prosthesis. I probably do at least 50 patients a year. I'm doing total joint prosthesis and orthognathic surgery. Now, part of that is because with my reputation, I get referred in bad patients with TMJ problems. And so my patient population is maybe a little bit more heavily weighted towards patients with TMJ problems. Thus, a lot of those patients will end up with total joint prostheses. In doing total joint prostheses in conjunction with orthognathic surgery, I've always done it all in one stage. But if you're new at this, you're a surgeon, it may be better to do things in stages. For instance, if you have an ankylosis case, you may want to go in and remove the bony ankylosis first, get back to good basal bone, take your CT scan, have the prostheses made, and come back secondarily and put the prostheses in. Now, with my experience, I do all that in one stage. But a new, young, or inexperienced surgeon, it would be better in some of these cases to do it in 2 stages. How would you predict autorotation of the mandible in the STO? Now, your autorotation is different than selective autorotation or counterclockwise rotation that I'm doing. Autorotation is where, if you have, for instance, an open bite, that you do osteotomies on the maxilla and you move the posterior maxilla upwards and allow the mandible to autorotate upwards and forwards into occlusion. So that's different. I don't typically do autorotations. I always, most always selectively reposition the maxilla and mandible because most of the time I'm going to be doing double jaw orthognathic surgery, because I think that can get me the best functional and aesthetic outcomes for my patients. Let's see. No new now. We may finish. Okay. Let's see here some more. How reliable is the measurement of airway on the lateral cephalogram? I believe that it's fairly predictable. Let's see. I believe it's quite predictable, but it's only 2-dimension. If you have a CBCT scan, you can do a 3-dimensional analysis of the airway, which gives you significantly more information. Could the MyTech anchor cause partly condylar resorption? The MyTech anchor in itself does not cause condylar resorption. The disease process that's present that may not have been recognized will cause condylar resorption. If the mytec anchor is not used properly, in other words, the disc not adequately mobilized and put back in proper position, then you may still continue to have condyle resorption. If you're putting the disc back in position for the wrong indication, let's say the patient has juvenile idiopathic arthritis with a displaced disc, and you put the disc back, in that case, the resorption is going to continue, not because of the anchor, but because of the disease process. If you have a reactive arthritis in the joint caused by a bacteria or viral entity, and you put the disc back in place, you may continue to have condyle resorption, not related to the mytec anchor, but related to the disease process. So the mytec anchor in itself does not cause condyle resorption. It's the disease process that may or may not be accurately diagnosed that causes continued bone resorption in the joints, regardless of whether the mytec anchor was placed or not. Number 3, when controlling the load on the temporomandibular joint in the event of a displacement of the disc, the posterior disc tissue adapts and begins to act as a disc. Let's see. When controlling the load on the temporomandibular joint in the event of displacement of the disc, posterior discal tissues adapt and begin to act as a disc. Turns into a secondary disc. This is probably some inaccurate information. What the person's asking is if the disc is displaced, that bilaminar tissue will eventually become a little bit more firm and act like a disc. No, I would say no. Particularly if a patient needs orthognathic surgery. I showed on Monday what happens with anteriorly displaced discs when you just do the orthognathic surgery on those cases. Condyle resorption occurs in a high percentage of those patients. A high percentage of those patients will have increased pain after the orthognathic surgery when the discs are not properly put in position, or if the discs are non-salvageable, that a total joint prosthesis is not used. So the bilaminar tissues does not act as a disc. You may be able to get by a patient that you're not having to move the jaws at all with orthognathic surgery. Yeah, some patients may do well with a displaced disc and do okay. A lot of patients won't. But if you need orthognathic surgery, leaving the disc out of position is highly predictable for failure relative to surgical stability and pain. Does the professor's patients wear splints in the preoperative period? No, only if they find it more comfortable while we're waiting for surgery, they could use a splint. What I don't like about splints is it does tend to make patients clinch more. When something foreign is put in between the teeth, for a lot of patients, it makes them clinch more. Now, if you have a joint problem and significant pain, using a splint, even though it may make the patient clinch more, it may help take some of the stress off the joint. So splints can be useful. I don't routinely recommend them pre-surgery, and I don't use them after surgery either. How does the professor feel about intraoral access during condylar resection? There are some papers out there. In fact, I've reviewed some of those papers where you approach the condyle from intraoral. I think it's somewhat risky because you don't have any control over the position of the articular disc. There's some articles that have used the intraoral approach, for instance, in treating osteochondromas of the condyle. Yeah, you can get in there, you can remove the tumor, but you don't have a way of controlling the position of the disc, which may now then be positioned more anterior because of the vertical height loss. You can't recontour the condyle very well. It's a novel technique, but I think it provides a lot of compromise as compared to the direct access that you can get from a endaral or pre-auricular kind of approach. What does the professor think about drugs that inhibit tumor necrosis factor, matrix metalloproteinases, interleukins such as methotrexate, Enbrel, simvastatin? So what you're talking about is the RNET protocol. We're seeing papers come out now, and many of us have seen patients that have been treated by that protocol, and it doesn't work. It doesn't stop the resorption in many of the cases. Particularly with the methotrexates, Enbrel, Humira, those kind of medications, there are a lot of side effects with those, including cancer forming and so forth. But they don't fix the joints. They may slow down the resorption process in some cases, but they don't fix the joints. If you've had a pre-existing displaced disc, it's still going to be out of place. If you have juvenile idiopathic arthritis, they're going to continue to have some condyle resorption. I see quite a few patients, particularly with juvenile idiopathic arthritis, the young kids who are put on these medications, their condyles continue to resorb. It may slow it down a little bit, but it doesn't stop it. It doesn't reestablish a normal condyle once those condyles are resorbed. So if a patient has multiple joint issues, other joints involved, polyarthritis, hey, these medications may work well. They may help, better stabilize some of the other joints. The difference with the TMJ joint relative to other joints is that the growth center of the condyle is just underneath the fibrocartilage at the top of the condyle. All other joints, the growth centers are away from the functional surface of the condyle. So when the condyles are involved in, for instance, JIA, rheumatoid arthritis, any of those conditions, that growth center gets destroyed. And so in the young patients with JIA, the mandible is not going to grow. You can give them all those medications you want, but once that growth center's damaged, it's not going to grow. You're still going to have a jaw deformity that's best treated with a total joint prosthesis and orthognathic surgery. Let's see. I hope I answered all the questions. Are there any other questions? You all asked some very good questions this time. That was very, very good. I appreciate that and hope I answered them appropriately for you. I hope that this presentation today was helpful in reference to sleep apnea issues. Again, we are the best people, the orthodontists and the oral maxillofacial surgeons working together to treat obstructive sleep apnea involving the upper airway. We should be heavily involved in this area as we can provide the best outcomes that no other specialty can provide. So I thank you for the opportunity to talk with you, and this will end our program for today. Thank you so much for the opportunity to spend time with you.